Assalamu alaikum. Good morning, Mr. Chairman, ladies and gentlemen. I'm very thankful to the local organizing committee, SHA and ESC for putting day and night efforts to bring latest science to the local area. This is really needed in this time while every day we see different studies and we face different problems along with the day-to-day medical practice. Today I am going to share with you the story of a Saudi lady which represents our day-to-day daily medical practice problem. This is a story of a 66-year-old Saudi lady who presented to our ER with the complaint of palpitation that was associated with lightheadedness. She lived in a village and was hard of hearing as well. She was taking perindopril for her blood pressure and oral hypoglycemic for her type 2 diabetes mellitus. Her physical examination revealed that she's a thin, lean, elderly lady, but quite well-oriented, functionally good capacity, and her pulse was irregular with the rate ranging from 120 to 130. Though the blood pressure was uncontrolled and chest auscultation revealed few bibasal crepitations. Otherwise, there was no examination findings on the examination. Her baseline blood counts and chemistry were within normal limits, and urine analysis showed proteinuria. Her ECG done in the ER that showed atrial fibrillation, as we mentioned before, with uncontrolled heart rate. Though during the stay in the ER, within half an hour, her atrial fibrillation spontaneously reverted to sinus rhythm. She was managed with diuretics in the ER and optimizing the antihypertensive medication, and she responded very well. And her medication were optimized by addition of hydrochlorothiazide, and perindopril was increased to 10 milligram, keeping in view that her blood pressure was uncontrolled. She was discharged home in pretty good condition, and she was asymptomatic in sinus rhythm with the label of accelerated hypertension and first episode of atrial fibrillation. And the plan was to see her in the clinic 1 week after with the Holter monitor to look for whether there is any recurrence of the atrial fibrillation or not. The Holter monitor showed paroxysmal atrial fibrillation. Her CHA2DS2-VASc score was assessed, which was found to be 4, and Has-Blood score was 2. So as per guideline, dabigatran 150 milligram twice daily was added to her regimen. One month later, she presented to the ER again with the complaint of acute chest pain associated with shortness of breath. Hemodynamically, she was quite stable, and examination revealed CLIP class 2 Krebs on auscultation. CLIP class 2 Krebs on auscultation, and troponin I was elevated to 7 nanogram, and now her eGFR, that is estimated glomerular filtration rate, was 40 ml per minute. That points toward her diabetic kidney 2 to 3 grade. Blood counts were normal. Clotting profile and anti-10 effector activity was within therapeutic range. Her ECG showed ST elevation in the anterolateral leads, though she was in sinus rhythm. And the chest X-ray was suggestive of pulmonary congestion. Now, we took the patient to the cath lab in view of acute ST elevation MI with the intent to do the primary PCR. Cath revealed tight LAD stenosis at the junction of the diagonal branch. She received drug-eluting stunt, Zion stunt, with very good TIMI-3 flow. Her echo revealed akinetic antoseptal wall as well as the apex. Now, we were in trouble. We were in dilemma. She's an elderly lady, thin, with a high CHA-2DS score, living in a village. And not only the high CHA-2DS score, has blood score was also 3. The case was discussed, and our options were considered. What are the antithrombotic options? She's already on dabigatran. Of course, she received drug-eluting stunt, and she has to be on antiplatelet as well. There were different options which were considered: triple antithrombotics, dual antiplatelet, oral anticoagulation, and one antiplatelet, or oral anticoagulation only. Patient was switched to rivaroxaban, 50 milligram, 1 OD, along with aspirin and Plavix, because now she had a renal dysfunction and she received already drug-eluting stunt in the setting of acute coronary syndrome with a very important vessel, and she lives in a village. She presented to the ER 5 days later with multiple skin bruises. Now we were in the dilemma again. Blood count showed thrombocytosis, but her hemoglobin, hematocrit were stable, and anti-10 effector activity was in therapeutic range. Reassessed CHA-2DS score was 6. Has blood score was 5. So problem has increased. What are the antithrombotic options now? Continue triple antithrombotics, dual antiplatelets, oral anticoagulation, one antiplatelet, oral anticoagulation only. These all options were rediscussed among the heart team members. And it was agreed that patient should be observed very closely because she already presented with the bleeding, though it is minor, but still it is a bleeding, and she has high risk. So, and it was decided to continue on rivaroxaban and Plavix for 6 months and see how she behaves, and depend on the clinical situation during this 6 months, rediscuss, reevaluate, and decide the further management plan. She was treated conservatively for the bleeding by observation only, discharged home on the medication mentioned above with closer follow-up. With these multiple dilemma taking decision while facing critically ill patient with very high risk, we need to answer what other measures may be taken to prevent rebleeding in such cases, because it represents just one of the daily medical practice problem. It's not the only case. Do we need local guidelines on novel anticoagulants? Because different population behaves differently, respond differently to different medication. Can we extrapolate studies done in other cohorts to our population? Is it that simple in such high-risk patient? Do we have a specific reversal agent for NOACs if such patients come with the major bleeding? With these questions, I will conclude my talk, and thank you very much again for giving me this opportunity to share day-to-day medical problems.